We can start off now. Okay, welcome to today's class on management of unknown poisoning. So it's a brief introduction and about unknown. It's in general a discussion on how to manage, how to diagnose a case of unknown poisoning. ಇದು ಇಲ್ಲಿ ಮೂವ್ ಆಗೋದು ಸ್ಲೈಡ್ ಹಾಂ ಆಮೇಲೆ ನೆಕ್ಸ್ಟ್ ಇದಾ ಅಲ್ಲೇ ಮಾಡಬೇಕಾ ಅಲ್ಲೇ ಮಾಡ್ತೀನಿ. So introduction, poisoning is a worldwide problem that consumes a substantial healthcare resources and causes many premature deaths. So burden of serious poisoning is carried more in the developing world than the developed world. So poisoning related morbidity and mortality is also a significant public health concern in developed world also. So in India, the incidence of poisoning is remained to be uncertain. Around the world, around 1 to 1.5 million cases occur every year, and out of which 50,000 succumb to it. So peak incidence is peak incidence being in 20 to 30 years of age group, and rare cases occurring after, or a very few cases occurring after the age of 65 years. Half of the poisoning in India are suicidal and followed by accidental poisoning in about 1/4 of the proportion, and also homicidal poisoning. Homicidal poisoning contribute less to the proportion. Both suicidal and homicidal poisonings are more common in India than in Western countries because the ease with the availability of the poison. Males are more affected than females, and most victims are from the medium to low socio-economic group, primarily from the rural areas. Aluminum phosphide is the commonest poisoning agent reported from the rural areas, while the organophosphorus agents are the commonest report from the other areas. So therapeutic drugs are responsible for only a minor proportion, followed by the food poisoning cases. So route of exposure. The route of exposure occur most commonly by ingestion, and other routes include inhalation, insufflation, cutaneous and mucous membrane exposure, and also injection. Approach to patients. So first, whenever a patient has come to the suspected poisoning, first identification of the poison is important from the history, reliable history, and circumstantial evidence, and also the signs and symptoms at the arrival of the patient to the hospital. And if at all, if little doubt about the poisoning, so we have to think of an alternative differential diagnosis. And apart from this, in these patients we have to identify the comorbidities. And next is plan of treatment. We have to stabilize the patient's vitals, removal of the unabsorbed poison, use of antidote in these patients, enhanced removal of poison from the body by various other methods, and supportive management. The next part of the approach is we have to give a psychiatric counseling, especially in patients with the suicidal cases. So there are some criteria to determine whether exposure is non-toxic. So whether poisoning is toxic or non-toxic, this is necessary mainly to have a plan for the management for the case. So how to decide whether exposure is non-toxic? One is an unintentional exposure to clearly identify a single substance. So patient says that it's an accidental consumption and he knows what he has taken. It's an accidental. So that is an unintentional exposure to a clearly identified single substance. And an estimate of the dose is known, what he has consumed, he knows how much he has taken. And recognized information source, that is from the poison control center, which confirms that the substance is non-toxic, and the reported dose. So because why should we know these things, whether the whatever the substance consumed is toxic or non-toxic? Because the most of these asymptomatic patients with non-toxic exposure may be discharged after a short period of observation, and even like they can ask them to come for a outpatient basis. So serious clinical effects or a morbidity mortality occurs in less than 5% of the acutely poisoned patients in most of the presenting to the hospital, and inpatient mortality rate is less than 1%. So coming to the brief about the history and examination. So history, whenever an arrival to the and a patient coming to the casualty with a history suggestive of unknown substance consumption. So we have to ask a proper history. So proper history taking may be different in a patient who is presenting in an unconscious state. Attempt should be made to ascertain the nature of the poison, quantity of the poison consumed, and mode of exposure, and the time of exposure. And if there is any like a history suggestive of vomiting subsequently, we have to ask them, is there any subsequently vomiting following the consumption, and which has resulted in the spontaneous expulsion of the ingested poison. Then if it is a doubtful about the poisoning, you have to suspect if there is a sudden, unexplainable, unpredictable illness preceding in a healthy individual. A history of recent consumption of an unknown drink or a food item from an unverified source, or a depression or an acute stress. So patient who have an acute stress or a depression, so we have to take this history, psychological history has to be taken whenever we want to identify the suspected case of poisoning. So coming to the resuscitation part, first is we have to take a history, we have to arrive at the provisional diagnosis where the patient has taken a substance or a drug overdose or a toxic drug or a poison. So first assessment of the patient's clinical condition is very important. It provides a baseline. So a baseline history which can be subsequent assessment and also outline the institute emergency measures. So we have to assess the sensorium and vital signs. Okay, and we have to do a quick, thorough physical examination is essential. So in absence of any focal deficit or just an altered sensorium without any parasympathetic or sympathetic symptom could result from a intake of a cerebral depressant or a sedative. Pupillary signs of cholinergic or anticholinergic stimulation may help to aid the diagnosis. So meiosis, for example, meiosis is observed in patient who has come with a OP compound consumption or a narcotics, barbiturates, phenothiazines, clonidine or a phencyclidine. Mydriasis is seen with atropine, MAO inhibitors or nicotine or a tricyclic antidepressants. So apart from the pupils, the other clue to the diagnosis is one is skin color. Skin color is helpful at times, like a cherry red color seen in carbon monoxide poisoning. Cyanosis, in absence of hypoxia, it can be methemoglobinemia, and presence of a perioral corrosive burns or a intraoral ulcerations and congestion suggest attempt at a corrosive ingestion. And odor of the poison, which is most evident from the clothes, skin or breath odor, helpful in cases of ethanol, aluminum phosphide poisoning, and also in a organophosphorus poisoning. So color of the urine again helps. Color of the urine yellow resulting could be due to involvement of the liver, hepatotoxicity, or black color urine due to occurrence of a hemolytic reaction. So this is not very clear. So this table mainly says the examination of the poison patients, and there are some clues here. So one is that general appearance of the patient. So we have to see the appearance, dress or odors, mental state, nutritional state and temperature. So this is examples of a clue, that is a scalp hematoma. It can be intracranial injury. So if the malnourished patient, so you have to suspect IV drug abuse or addictions or HIV, or a smell of a bitter almonds, like in case of a cyanide toxicity. So coming to the central nervous system, clues to the central nervous system, that is if conscious state is fine, if there is any alteration in the pupillary size, so we have to work up accordingly. Okay, so presence of a cerebellar functions or disturbance in the cerebellar functions can be in a anticonvulsants overdose or a ethanol toxicity. So cardiovascular, if the patient has bradycardia, tachycardia, if patient has a bradycardia, usually it occurs in patient with organophosphorus consumption. Respiratory involvement, oxygen saturation, respiratory rate, and we have to examine for chest auscultation. So if the oxygen saturation is low, again if patient has a shallow breathing which can occur in a organophosphorus or OP compound poisoning, and presence of bronchoria or a crepitation. So these patients, they can have aspiration pneumonia can develop easily. Then we have to examine the GI system, mainly oropharynx, abdomen, and bladder, that is a lower abdomen. So oropharynx, again we have to look for a corrosive, that is a ingestion, corrosive burns, corrosive poisoning, and sometimes an anticholinergic toxicity, patient can have a urinary retention. And presence of a hypersalivation, it is a cholinergic toxidrome. So we have to examine the nerves. So that is a peripheral nerve, reflexes, fasciculations, tremors. So mainly if the lead pipe rigidity is there, so it can be neuromuscular malignant syndrome. And the dermal, that is a skin. So presence of bruising, cyanosis, flushing, then the any clues of injection sites. So these are the different clues where we have to examine the patients in detail to know the clue. It is especially in case of a unknown poisoning we have to. So these are the different toxidromes, that is an like an anticholinergic, usually atropine. So they can present with the altered mental status. They'll have a mydriasis, dry flesh skin. They can have a urinary retention and dry mucous membrane. So these patients can have a atropine in a overdose can cause seizures, arrhythmias, and rhabdomyolysis. So cholinergic, organophosphorus and carbamate insecticides. So the patients can have a salivation, lacrimation, vomiting, defecation, bronchoria, bradycardia, meiosis, and even a seizures. So if then ethanol consumption or central nervous system depression, and patient can have a ataxia, dysarthria, and even these patients will have a odor of a alcohol, that is an ethanol breath will be there. So then apart from this, patient can have involvement of the extrapyramidal system, mainly in a patient with haloperidol or a risperidone. This usually occurs patient who have a psychiatric illness and all these medications. Or sometimes we have to ask if patient is not having any history suggest of a psychiatric illness, his or her family members will be on these drugs and they can come with a consumption of these medications. So mainly these patients can have a dystonia, muscle rigidity, choreoathetosis, hyperreflexia. This is mainly a drug overdosage. Then the other group of drugs are hallucinergic, that is again it is an LSD or a phencyclidine. And a patient hypoglycemic toxidrome, that is anti-diabetic medication. So use of if some person comes with excessive consumption of glibenclamide, that is a sulfonylurea, so they can come with the features of hypoglycemia, that is diaphoresis, tachycardia, reactive hypertension. So then the patient who was taken an antipsychotics, that is a NMS, neuroleptic malignant syndrome. So patient can come have usually will have a severe muscle rigidity, hyperpyrexia, and altered status. So opioid is codeine, heroin, and morphine. So this is again a continuation of the same table. So with the salicylates, that is an aspirin overdose. So patient aspirin overdose, usually patient will have a acidity, that is a like patient will have a nausea, vomiting, even patient can have a tinnitus, tachypnea, tachycardia. So then the other group of toxidromes are sedatives and hypnotics. One is benzodiazepines and barbiturates. So in these category, patient will have a central nervous system depression, bradycardia, and even they can in a barbiturates poisoning, severe overdosage, lethal dose, it will cause a respiratory depression. Apart from this, consumption of serotonin, SSRI, so they will develop a altered sensorium, altered mental status. So these are the different toxidromes where a patient can come. This we have to suspect mainly on arrival to the hospital based on the clues to the conception and an examination, pupillary reaction. Is there corrosives, means they'll have a ulcers. So coming to the management part. So one is apart from the routine investigations. So we have to apart from this routine investigations, that is one is we have to get a routinely blood hemogram, complete hemogram, blood sugar levels, renal function test, electrolytes, urine analysis. Okay. So in a patient with suspected OP compound poisoning, we have to send a pseudocholinesterase levels. Then apart from these are the routine investigations, we have to send a ometers, urine and a gastric lavage samples and a suspected skin scrapings preserved and sent for a toxicological screening. Suppose if it is an unknown poisoning, patient is in deep comatose or a CNS depression, so it is mandatory that we have to send a gastric lavage samples for the analysis of barbiturates levels, benzodiazepine levels. Okay, so this is routinely done when we suspect a CNS depressant intake or a overdose. The next step is once we have sent a routine investigation, simultaneous removal of unabsorbed poisoning. So one is we have to change the dressings, clothes needs to be removed in cases of a OP compound poisoning. So because the poison would have been spilled on the cloths and get absorbed through the skin, through the dermal. So in cases of a inhalation, that is carbon monoxide poisoning, patient should be removed from the inhaled area, that is from the room, and brought to the fresh air, and his skin, eyes should be thoroughly washed in case of a corrosive or a burns. So adequate hydration is very important. It is the foremost step since the most of the toxins or poisons are excreted by the kidneys. And adequate hydration helps maintain the blood pressure, which in turn maintains the perfusion of the kidneys, and also helps in the renal excretion of the poisoning, that especially in drug overdoses, that is barbiturates and benzodiazepines. And decontamination is required for the toxic exposure, affecting largely dermal areas. So healthcare, whenever we are providing the treatment for poisoning, healthcare providers should wear a personal protective equipment, number one, and universal precautions like a gown, gloves, eye protection should be worn. Okay, and so ocular. So after this, we have to remove the poison, that is decontaminate. We have a ocular decontamination and a gastric GI decontamination. So ocular decontamination mainly whenever there is an alkali burns to the eyes. So it requires decontamination, requires a local anesthetic, that is 0.5% tetracycline instilled, and lid retractors to facilitate a copious irrigation with a crystalloid solution. We have to instill first a local anesthetic, and we have to retract the eyes with a lid retractor, and we have to irrigate the eyes with a normal saline. So alkali burns produce a greater injury than a acid burns due to the deep tissue penetration by the alkalis and liquefaction. It causes a necrosis. So the prolonged irrigation 1 to 2 hours may be required in case of a alkali burns. 10 minutes after the irrigation, allowing the equilibrium of a crystalloid and conjunctival sac pHs. So we have to test for the conjunctival sac pH. So irrigation should be continued until the pH is less than 7.4 in case of a alkali burns. And we have to ask the ophthalmologist for the further examination of the eyes. Next is GI contamination. GI contamination is, first is you have to ask whether patient, sometimes when before coming to the hospital only patient attenders would have induced emesis by a local or a conventional measures, or we can give a ipecac syrup to induce vomiting. So this is only theoretically emptying the poisons, emptying the stomach with poisons. Otherwise, we have to give a gastric lavage. So this is only the removal of the ingested toxin from the stomach by aspiration of fluid placed through gastric tube or a Riles tube. So lavage changes outcome within the if you do it in a early hours. So gastric lavage is most effective method to remove the unabsorbed ingested poison if it is performed 2 to 5 hours of ingestion, and it is contraindicated. The most important is gastric lavage is contraindicated in corrosive or a kerosene poisoning. So induction of emesis in hospital is not routinely done. It is not advocated because it is not an effective method of a GI contamination. Sometimes it can result in an aspiration, or it can induce a convulsions. So, or sometimes there is a danger of pushing the poison down into the small bowel from the dissection, and we are going to make a absorption more. So routinely induction of emesis is not done on the hospital treatment. So gastric lavage is the standard treatment done in the hospital. So one is this is the procedure. So ensure the protected airway. If patient is unconscious or a semi-conscious or a stomach, so airway should be protected. Next is we have to introduce a 36 or a 40F gauge or Riles tube. Position the patients on left side with the head down on the 20-degree down, and tube should be lubricated, and it should pass through the oral cavity or through the nasopharynx also, and esophagus distance equal to the between chin and the xiphoid process, and confirm the tube position by insufflation of air, and we have to introduce a lavage. So we have to introduce a 200 ml of fluid or normal saline or distilled water for the lavage, or even a warm tap water. Till what we have to continue this procedure till and we have to aspirate after introducing this 200 ml of distilled water or a normal tap water. We have to aspirate again. So we have to aspirate the stomach contents along with the whatever we introduce the fluid. So we have to continue the procedure till we get a return fluid is clear. So after that we can consider administration of activated charcoal via orogastric tube before. So then in another method follow apart from this GI contamination and ocular contamination. So GI contamination is universally done for all poisoning except a corrosion and a kerosene poisoning. Ocular contamination whenever there is a suspicious of an alkali or an acid burns. So coming to the another mode of contamination is urinary alkalization, or decontamination is urinary alkalization for an adult patient. So one is first is we have to get an electrolytes done before doing this procedure. We have to correct is there any pre-existing hypokalemia. So then is we have to give a bolus of sodium bicarbonate that is equal to 1 to 2 milliequivalents per kg intravenous bolus. Then followed by we have to infuse around 100 milliequivalents of sodium bicarbonate mixed with a 1 liter of 5% dextrose around 250 ml per hour. So apart from this, along with this, we have to add a 20 milliequivalents of potassium chloride. We have to add to the same solution to maintain the normokalemia, and we have to monitor both potassium and bicarbonate. That is, we have to do ABG every 2 to 4 hours to detect hypokalemia, or is there any excessive serum alkalinization. That is why we have to check the bicarbonate by doing the ABG, and we also check the urinary pH regularly every 15 or 30 minutes. We have to aim for the urinary pH of 7.5 to 8.5 whenever we are planning for the forced alkaline diuresis. This method is also called as forced alkaline diuresis or a urinary alkalization, which is done predominantly for the patients who has consumed barbiturates, that is a phenobarbital overdose. If pH is not yet come to the 7.5 to 8.5, we can repeat the cycle again. We can add 100 milliequivalents of soda bicarbonate to the dextrose, and we have to give it a infusion. So this is the again, so urinary alkalization indication is one is salicylate toxicity, so and mainly phenobarbital toxicity. Contraindications for this urinary alkalization is patient who have a cardiac dysfunction or a LV dysfunction, who have a pre-existing fluid overload or pre-existing uncorrected hypokalemia. So these are the contraindications for urinary alkalization. So other than that, the complication of this procedure is one is patient can develop a hypokalemia, so we have to take care of that part by giving a potassium infusion along with the soda bicarbonate infusion. Next is we have to see to it patient should not get into volume overload whenever we are doing this cycle. And serum alkalizes, that is patient can develop a alkalosis, so we have to take care of that part also by doing a repeated ABG. So coming to the antidote, so we have done a history, we have taken, we have done a decontamination by removing the cloths, and we have done a gut decontamination. If required, we have done a urinary forced alkaline diuresis. Next is antidotes. So what are these antidotes? Antidotes are the agents which counteract the effects of poison. So universal antidote, what we call is a activated charcoal. It acts mainly by absorbing and retaining within its pore the mineral or organic poisoning. So we have to give 50 gram diluted in a water. We can give every 4th hourly. So it can be given as a cathartic agent, that is it can cause a, even it can cause a diarrhea also. It agents in a sorbitol. Then the other universal antidote is potassium permanganate, because it has got an oxidizing property, but it is a non-specific chemical antidote. So usually it is 1 in 2000 now is used for gastric lavage in opium. So whenever we can introduce again potassium permanganate diluted 1 in 2000 dilution, we can introduce this solution into the GI tract, that is into the stomach through Ryle's tube. So for a as gastric lavage in opium poisoning. So this is the list of specific antidotes that I have just told the few common toxins antidotes. That is, one is atropine is a antidote for a organophosphorus poisoning, naloxone for a morphine overdosage, that is BAL, that is dimercaprol chelating agents for arsenic or mercury, calcium sodium sodium 18 for lead poisoning, desferoxamine, so commonly we should know that is iron overload, iron poisoning, D-penicillamine for a heavy metal poisoning like a lead, gold, mercury or a copper. So the rare modality of treatment in patients with poisoning is extracorporeal removal. That is extracorporeal removal technique, which can be hemodialysis, hemoperfusion, continuous renal replacement therapy, but they have a limited indications. In not all the patients who come to hospital with the poisoning should not be subject for extracorporeal removal. So this ECMO is first of all, this facility will not be there in all the centers. Okay, so usually these extracorporeal techniques will be this mainly commonly used is hemodialysis will be used only predominantly in a patient with a severe barbiturates overdose. So coming to the next topic of today's class is acid base. Just I'll tell you briefly acid base disorders. So the first I'll go with the electrolyte imbalance, then I'll go with the acid base disturbances. So coming to the distribution of total body water, all of you know water is the most abundant fluid in the body, comprising of the 60% of the total body weight in males and 50% in females. So 2/3 of this is distributed intracellularly and 1/3 is present in extracellularly. Out of extracellular compartment, 3/4 is present in the interstitium and remaining 1/4 is distributed intravascularly. So ionic composition, that's the electrolyte sodium, potassium of the extracellular and intracellular fluid is different. The Plasma has a higher protein concentration. So due to the net negative charge of the proteins, they tend to hold a slightly higher concentration of sodium inside in plasma. Plasma osmolality we calculate by using this 2 into sodium plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. Normal osmolality is 290 to 310 milliosmoles per liter. So any abnormalities in the water homeostasis are responsible for the sodium disorders. So in normal individual, serum osmolality is maintained by water intake and also circulating AVP, that is arginine vasopressin. Defects in water intake or an AVP, so both can lead to sodium disturbances. So coming to the hyponatremia. Hyponatremia is defined as a serum sodium less than 136 millimoles or is the most frequent electrolyte abnormality which come across in hospitals or in patients. Coming to the causes of hyponatremia. So these are the causes of hyponatremia. One is causes of hyponatremia is classified into euvolumic hyponatremia, hypovolumic hyponatremia, or hypervolumic hyponatremia. So euvolumic hyponatremia or isotonic hyponatremia usually we get in SIDH or a hypothyroidism. Hypervolumic or hypertonic hyponatremia is hyperglycemia. Hypovolumic hyponatremia usually whenever there is a fluid loss, that is fluid loss, it can be renal loss or it can be GI loss. Okay, so extra renal loss is mainly GI loss like diarrhea and vomiting, then the sweating, third space loss. So these are the causes for hypovolumic hyponatremia. Euvolumic hyponatremia is again a primary water gain. So primary is a secondary sodium loss or a water gain is more than the sodium loss. So one is SIADH, hypothyroidism, adrenal insufficiency. Okay, these are the common causes for a euvolumic hyponatremia. Coming to the hypervolumic hyponatremia. So that is a primary sodium gain more than the primary sodium gain than the water. So usually it occurs in patients with a congestive heart failure, then nephrotic syndrome, cirrhosis and pregnancy. So again, based on the duration of occurrence of hyponatremia, this can be classified into hypovolumic hyponatremia, acute hyponatremia and chronic hyponatremia. So hyponatremia occurring over a period of 48 hours is acute hyponatremia and more than 48 hours lasting is chronic hyponatremia. Why should we know this duration is mainly for the treatment part. Okay, so then there is another entity called as pseudo hyponatremia. Usually where sodium is less but the osmolality and tonicity of serum is normal. Coming to the clinical features of in general clinical feature, this is general clinical features. So signs and symptoms depend on the degree of hyponatremia and the rate of fall in serum sodium levels. So nausea, malaise are the earliest symptoms. So whenever there is a serum concentration, sodium concentration between 125 to 130, acute, so patient can complain of a nausea and a malaise. So when it goes below 120, that is 115, patient can have a CNS symptoms, that is headache, lethargy, muscle cramps, confusion, disorientation and obtundation. So patients with chronic hyponatremia, why we should know this category is they'll be asymptomatic despite of a sodium concentration even very low or below 115 or 118, patient will be asymptomatic. This is mainly because it takes cerebral adaptation. So during hyponatremia, what happens is there is a transcellular fluid shift. So this brain in mainly in the brain there is a fluid shift. That's a transcellular fluid shift. Brain cells have exposed to a hypotonic plasma. So there is a shift of the fluid from the plasma to the cell. So there is a cellular edema. So leads to cerebral edema. So this is an early adaptive response of the brain cell to the hyponatremia is by the loss of water into the cerebrospinal fluid following the extrusion of sodium and plasma potassium from the brain cell. So then the next is late adaptive response will occur through the extrusion of organic osmolytes such as myo-inositol, glutamate, then the taurine. Okay. So classification of hyponatremia. So hyponatremia comprises of 22% of the hospitalized patients. So classification is hypovolemic, euvolemic, hypervolemic based on the volume status. So hypovolemia leads to neurohormonal activation, increased arginine vasopressin. So AVP causes water reabsorption through V1 air receptors. So there is a dilution. Causes are mainly renal causes, GI causes. Renal causes are diuretic excess, salt losing conditions. Then the GI loss is vomiting, diarrhea, third space loss, and also in patients with burns and pancreatitis. Hypervolumic hyponatremia. Hypervolumic hyponatremia is there is an increase in total body sodium by proportionately increase in total body water. So can be due to acute or a chronic renal failure. Most of the times we come hypervolumic hyponatremia in nephrotic syndrome, cirrhosis, congestive cardiac failure, all this in a fluid overload status. So congestive heart failure, cirrhosis and nephrotic syndrome. In the cirrhosis and a congestive heart failure, the sodium acts as a prognostic indicator. Euvolumic hyponatremia usually seen in patients with hypothyroidism, and I have told already it is secondary to adrenal deficiency insufficiency, SIADH. Okay, so clinical features, there is a generalized cellular swelling due to the movement of water from hypotonic ECF to intracellular. So mainly neurologic symptoms are mainly involvement of the CNS, that is features of cerebral edema. Patient can have a headache, nausea, vomiting. If it is not corrected or the hyponatremia is not recognized, so patient can develop a brain herniation, even develop a coma. So acute hyponatremia. In which condition we see acute hyponatremia? Most commonly acute hyponatremia is seen in post-operative patients following the administration of a hypotonic saline infusion. So whenever there is a hypotonic saline infusion, so there is an increase in AVP, and usually it is seen in marathon runners. So there is a non-osmotic increase in arginine vasopressin leading to hyponatremia. Hello, class class. So these chronic hyponatremia symptoms developing over 48 hours. So there is a late adaptation of the brain. So because of the there is a shift of the fluid. There is an efflux of the osmolytes like a glutamate, because there is a cellular swelling will be there. There is a, because in patients with hyponatremia, there is a transcellular shift of the water to the cells in the brain cell. So the brain cell will get swollen. The patient will develop a cerebral edema. This happens in acute hyponatremia. In a patients with chronic hyponatremia, that is a hyponatremia developing slowly over more than 48 hours because of the time interval. So even though there is a shift of the water into the cells, but the whatever the osmolytes like glutamate, betaine, taurine inside the they'll get effluxed. So there is a balance of this osmolality and water entry. So these patients will have a symptoms are less. So most of the times these patients can nausea, vomiting, gait disturbances or a cognitive dysfunction. Coming to the diagnosis and management of hyponatremia, in these patients, whenever we suspect a hyponatremia, so an elderly patient with comorbidities or a hypertensive who is taking a diuretic, who has come with the features of altered sensorium or generalized weakness, we have to suspect hyponatremia. Detailed history, physical examination, appropriate laboratory test in selected patients, and also the response to volume expansion. So these are all mandatory in all these patients. So we have to check the plasma osmolality and urine osmolality, urine sodium excretion, serum electrolytes, blood sugar levels, renal function tests, and additional investigations whenever needed. Additional investigations means whenever there is an euvolumic hyponatremia, we need to do additional investigations like a thyroid profile levels and a serum cortisol. When we suspect adrenal insufficiency, we have to get a cortisol levels. Then after the history, we have to examine the patients for volume status, whether patient is hypovolumic, euvolumic or a hypervolumic. Apart from that, we have to get a routinely chest X-ray, electrolytes, serum glucose, and we have to work up for a adrenal insufficiency if we suspect. Then we have to get urine electrolytes. Why we should do urine electrolytes? This is mainly to differentiate between the hypovolumic hyponatremia of renal or a GI origin. So this is the flow chart. So assessment of the volume, hypovolemia, total body water will be less, but the sodium also more reduced. Euvolumia, water will be mildly increased, sodium will be more or less normal. There won't be any visible edema. Hypervolumia, patient will have a visible edema. So in this hypervolemia like congestive cardiac failure or cirrhosis, they'll have a total body water gain will be more than the disproportionately more than the sodium gain. Okay, so these three you have to see about the volume status of the patients. Next is, so hypovolemia, I have told there are many causes. Let's say renal cause, extra renal cause. Renal cause, diuretic therapy, renal losses, diuretic treatment is most. So how do we know renal cause? We have to get a urinary sodium. If suppose patient has a history of vomiting, diarrhea, or a patient has got a pancreatitis, that is a third spacing fluid loss, or a burns or a trauma, so we can easily assume this is an extra renal loss. So we need not do this serum sodium levels, the urinary sodium assessment. When the patient doesn't have all these features, so we have to think of doing the next step, that is urinary sodium. So if at all, if it is needed. Then the euvolumic hyponatremia, this is glucocortical deficiency, hypothyroidism and SAH. Again we have to get a urinary sodium. So whenever there is an hypervolumic hyponatremia, so even the CKD patients can have this, and congestive heart failure, liver cirrhosis patient can have. So once again in CKD patients, urinary sodium excretion will be more than 20, whereas in nephrotic syndrome patients or a congestive heart failure, urinary sodium excretion will be less than 20. So this is mainly once you assume the volume status, take a history and confirm the history, diagnosis. So you have to do additional investigations. When you think of a cardiac failure, definitely you have to get an echocardiography, ECG. When you do think of a cirrhosis of liver, definitely you have to get an ultrasound abdomen. If you think a nephrotic syndrome, you have to get a urinary 24 hours urinary protein excretion. So if you think a CKD, then definitely RFT has to be done. So this is mainly based on our orientation of the patient. So next investigations has to be decided in workup or a hyponatremia. So these are the different causes for SID. It's a big list. SIDH, syndrome of inappropriate antidiuresis. So most of the times it can be a chronic infections like a bacterial pneumonia or a tuberculosis in respiratory system, or even it can be small cell carcinoma of lung, or other than that encephalitis, malignant meningitis, brain abscess. So these are the main common causes for SIDH. Arjun. So treatment. Treatment is look for the presence of symptoms, severity of the symptoms, decide about the urgency and goals of the therapy. So in patients with chronic hyponatremia, sodium is corrected by 8 to 10 milliequivalents per deciliter in first 24 hours. We should not cross beyond this correction. Otherwise, patient will go for a ODS, that is osmotic demyelination syndrome, that is an irreversible stage. So you should focus on the any reversible cause are present for the hyponatremia. So in hypovolemic hyponatremia, we have to treat the fluid loss. That is, we can infuse the intravenous isotonic saline. So correction should be slow if hyponatremia is present for more than 48 hours. And in hypervolemic hyponatremia, in patient with heart failure, we have to go for a fluid restriction and a diuretic therapy. So this is the formula, that is 0.6 into body weight multiplied by target sodium minus serum patient's present sodium concentration. So acute hyponatremia with CNS symptoms should be treated with a 3% hypertonic saline and increase plasma concentration by 1 or 2 milliequivalents, 12 milliequivalents. Sorry, there is some mistake here. So drugs used for treatment of hyponatremia, demiclocycline, and which is not available for the usage now. So Vaptons, that is an arginine vasopressin antagonist used mainly in patients with euvolemic hyponatremia or a hypervolemic patients, that is with heart failure or a cirrhosis. So one commonly used Vaptons are tolvaptan. It's a currently used V2 receptor antagonist. So hypernatremia, so nothing much. Hypernatremia is sodium level more than 145 milliequivalents per deciliter. Attendance. ಆಮೇಲೆ ಬರ್ತೀರಾ ಇನ್ನ 15 minutes. Clear there? Clear. So coming to the hypernatremia. Hypernatremia is defined as the elevation of serum sodium concentration more than 145 milliequivalents per liter. So causes of hypernatremia. So these are the causes, that is a net water loss. So whenever there is an insensible water loss through the sweating. Okay, so it's the most commonest cause for hypernatremia, or in ICU patient who is on a mechanical ventilator. So that is a commonest cause for a hypernatremia in ICU. Apart from this, NG-tube patient who is on fistula, diarrhea, burns, excessive sweating. So these are the causes for a hypernatremic hypernatremia. So commonest is net water loss, or when we administer too much or excessive administration of a hypertonic sodium solution also. Okay. So clinical features of hypernatremia, it is more or less like a CNS involvement as it is in hyponatremia. So patient can have altered sensorium, headache, nausea, vomiting. So again, degree and rapidity of onset of hypernatremia and age of the patient is important. So elderly patients will have a few symptoms till the sodium concentration there goes to 160, and patient can have an intense thirst. Sometimes these patients can develop a convulsions. So if the untreated hypernatremia goes beyond 180 milliequivalents associated with a higher mortality, usually this situation will come in patients who are admitted in ICU. So whenever we suspect hypernatremia, we have to take a history, current medications, and heat exposure, sweating, vomiting, diarrhea. So these are the these are the conditions where there is an excessive free water loss. That's a heat exposure, sweating, and a decreased fluid intake and thirst. Examination, we have to do a volume status and urinary volume, how much patient is producing the urine out, because the one of the cause for hypernatremia is diabetes insipidus. So you have to get a urine volume should be recorded, and urine osmolality or a spot urine samples or a 24 urine hour urine osmolar excretion should be done. So if the urine osmolality is less than 300, then the water loss is occurring through the kidney. Okay, in patients with central diabetes insipidus, we can get a ADH levels. So we have to work up for the diabetes insipidus. So we have to calculate the amount of water deficit and should be corrected through. So if the maximum rate of sodium correction should be lowered by 0.5 milliequivalents per hour and should not be more than 12 milliequivalents per liter per day. So hypotonic fluids are usually ideal, around 5% dextrose or low strength sodium chloride, that is 0.45% sodium chloride can be administered. So coming to hypokalemia, this is also one of the most commonest electrolyte abnormalities. So causes of again the hypokalemia, clinical manifestations of hypokalemia, muscle weakness, cardiac arrhythmias and rhabdomyolysis, renal abnormalities can occur. So causes of hypokalemia is again a drugs. Diuretic is the most common, patient who are taking a loop diuretic. And apart from that, beta-2 agonist inhalation, that is salbutamol nebulization, frequently can cause it can cause a transcellular potassium shift. Apart from that, like a primary mineralocorticoid excess. So if all these causes are ruled out, then we have to think of a endocrine disturbances in patients with a persistent hypokalemia. So diagnosis is we have to get a good history examination, and we have to ask for a source of, or we have to look into the source of potassium loss, whether it is renal or extrarenal loss, and we have to get an ECG changes of hypokalemia. Mainly there is a flattening of T waves, U waves, prominent U waves, ST segment depression, then the prolonged QRS interval, there is a widening of QRS complex. Once we suspect hypokalemia, we can go for a oral correction. Suppose patient is taking oral intake is good, or we can give severe hypokalemia. We can even do with the intravenous potassium supplementation for a life-threatening hypokalemia, or in patients who do not tolerate oral solution. So ECG monitoring should be done with a supplementation rate of 20 milliequivalents per hour. So when concentration should not be more than 40 milliequivalents in a peripheral vein, or 60 milliequivalents in a central vein. We should not give fast. So hyperkalemia is a potassium level more than 5. It's a life-threatening electrolyte disturbances. So manifestations, hyperkalemia per se has a few symptoms. It can cause a severe muscle weakness or a paralysis. So mainly ECG changes. So patient can have a tall T waves, tall tented T waves. So lengthening of the PR interval and loss of P wave, widening of the QRS complex. So there is a merging of TU wave with the QR. We call it as a sine wave pattern. So extreme cases, patient can develop a ventricular fibrillation. So it's the causes for hyperkalemia, mainly renal failure with metabolic acidosis or exercise, catabolic state. All the catabolic state can have a hyperkalemia. And patient with the beta blockers, beta adrenergic blocker, digital is overdosage. Main commonest is metabolic acidosis. Most common cause for renal failure and metabolic acidosis, most commonest cause for hyperkalemia. So mainly history and again not potassium loss, potassium gain, source of potassium, increased potassium. So hyperkalemia requires an emergent treatment because arrhythmias can happen whenever there is a potassium more than 7.5. So one is we have to have some goals. One is decrease membrane excitability. Thereby, even patient with the potassium more than 7, so we have to prevent the arrhythmias. Next is we have to do a transcellular shifting and promoting the potassium loss and removal of an exogenous source of potassium. So for membrane stability, we have to give a calcium gluconate. 10 ml of 10% should be given over a 10 to 15 minutes, but its duration is very short. So insulin causes extracellular shift of potassium into the intracellular. So we have to infuse around 10 to 20 milliequivalents of regular insulin to 20 to 50 gram of dextrose. So it can cause a fall in potassium by 0.5 to 1.5 in 15 to 30 minutes. But even this effect peak at 30 minutes, it lasts for hours. Whereas this calcium gluconate administration is only for a 30 to 60 minutes. We can give a beta adrenergic, that is a salbutamol nebulization, so it increases the cellular uptake of potassium. Then the final is like potassium binding resins like sodium polystyrene sulfonates we can give, and we have to ask the useful in dietary binding of potassium in the gut and prevents its absorption of a potassium. So then the most effective method of lowering potassium is rhabdomyolysis. So coming to the only 4 slides of acid-base disorders. So all of you know the normal pH is between 7.34 to 7.45. PCO2 is normal is 35 to 45 millimeter of mercury. Normal PO2 should be more than 80 millimeter of mercury, and expected bicarbonate in a normal individual should be 22 to 26 milliequivalents. So whenever there is a pH 7.4 is considered calculation purpose. So that is pH less than 7.4 is called acidosis. pH more than less than 7.4 is acidosis. More than 7.4 is alkalosis. Acidosis means there is a low bicarbonate. So that is metabolic acidosis. Respiratory acidosis means increased carbon dioxide. PCO2 will be increased. Metabolic alkalosis is high bicarbonate. Respiratory alkalosis is low PCO2 levels. So coming to the causes of metabolic acidosis, it results from the primary decrease in plasma bicarbonate. It can be either an excretion of bicarbonate or a utilization of bicarbonate. So commonest cause I have mentioned, that is one is diabetic ketoacidosis, salicylate poisoning, methanol poisoning, lactate, excessive lactate usually occurs in sepsis, and uremia. These are the common cause for metabolic acidosis. Metabolic alkalosis is only high bicarbonate level, usually gain of the bicarbonate or excessive volume contraction. So causes are usually omitting, NG tube aspiration, diuretic therapy, primary hyperaldosteronism. Barrett's and Cushing syndromes are, these are rare causes we need to work up. We will not come across this routinely. Routinely we can come across is omitting, NG tube aspiration and diuretic. These are the commonest cause for metabolic alkalosis. So respiratory acidosis mainly primary rise in PCO2. So hypercapnia almost always due to, we call it as a alveolar hypoventilation. Usually respiratory center depression, pulmonary disease, or a upper airway obstruction, or a neuromuscular disorders. Respiratory alkalosis is decrease in PCO2 due to hyperventilation. So whenever there is an hypoxia of any acute cause, that a pneumonia or a pulmonary embolism, so it can lead to washout of a carbon dioxide, leads to decrease in PCO2, can leads to respiratory alkalosis. Then the mechanical hyperventilation, sepsis, any type of pain, all these, even anxiety neurosis, all these can cause a washout of carbon dioxide, so leading to decrease in PCO2. So this almost completes the topic for 9-term students. Okay. Is there any doubt?